Our next speaker, maybe you know, Dr. Berenson, who practices treating myeloma patients at West Hollywood. Let me tell you how this came about, and we'll have Dr. Berenson start. Dave Sowers has been asking me for quite some time. Dave, why don't you raise your hand? Yeah, our member. Been asking me for quite some time. He says, when are you going to get Dr. Berenson out? Dr. Berenson saves lives. Dr. Berenson. So Dave just kept pursuing it with me. And so finally, we worked it out where we got Dr. Berenson, courtesy of Millennium. We are so happy. I know Dr. Berenson. If you haven't got a presentation of Dr. Berenson, you'll be wonderfully, pleasantly surprised. Dr. Berenson holds no punches. I take it, right? He's very honest. He'll say when he thinks something's crap, or so forth, which is refreshing. He's going to give you what he feels is the best plan of action in terms of myeloma. So without further ado, Dr. Berenson.
Okay, great. Thank you and good morning, and thank you, Dave, for putting up with my politics. We've been having fun over the last few years, especially last year, even this morning. And thank you, Heather and Millennium, for inviting me out as well. I see many of my patients in the audience, and they've been on every single drug you can possibly think of and not think of to treat myeloma. And so I have a lot of experience using these drugs, both on and off trials. So I'm happy to talk about those at the end. This talk has been approved by the, if you will, the priests and rabbis at Millennium, so it's pretty narrow, but you know, I have to give the talk the way it is, but I'm happy to talk about questions. People often ask me how I got interested in myeloma, and when I was at Stanford, my mother, I told her I wanted to be a poet, and she said, listen son, you can be a doctor, lawyer, or bum. So I had not a lot of choices, so she ended up with 3 doctors, 1 lawyer, and 1 bum. But, and I have something else in common with Steve. I actually am an identical twin. You probably didn't know that. I talked to him on the way over, and some of you know he's an oncologist trained at Stanford and has done a lot of biotech work. And in fact, we've done a lot of work on myeloma together as well. Not that we're doing any currently, but we're probably going to start some early next year. But I stumbled into myeloma many years ago when my wife was pregnant with my nearly 28-year-old, and she developed hand problems at that time. And my cousin Stan was a very prominent orthopedic surgeon over in Century City near Westwood. And he was taking care of her with the hand problems. It turned out it was thyroid. We learned that later. But he grabbed his kid in the swimming pool and cracked some ribs, and lo and behold, he had myeloma. And at that time, I was doing my fellowship and working at Caltech, coincidentally sequencing the genes that make antibodies. And you guys know this is a cancer of antibody-producing cells. So I said, okay, that's it. I'm going to work in myeloma. Now, Stan, unfortunately, a very gifted orthopedic surgeon, was 45 at the time, and he only lived 25 months. Boy, things have changed, as you're going to hear, and especially if you ask me about outcome data we're about to produce now. So I think things have just dramatically changed over the last quarter century, and it's thanks to new drugs, which aren't so new anymore, like our sponsor of today's talk, Millennium, that has Velcade or bortezomib, and there's lots of others I'm going to talk about. So this is an overview talk, and I'll kind of give my own opinions along the way, if you will. I'll talk about what myeloma is, how it's diagnosed, who gets myeloma, what kind of symptoms bring you into the office, the different types of treatment options, and how you can learn more about it. So again, it says it's not intended to replace conversations with your own doctor, nurse, or any other healthcare provider. So this again is a cancer of a type of white blood cell called a plasma cell, and that is in the bone marrow. So those cells are made in the bone marrow, and not really very much in other parts of the body, although my first paper back in '85 was to show it's actually in the blood, but it's pretty small numbers. The bone marrow that produces this normally has about 1/3% plasma cells. It's a very small number, but what happens in myeloma, these cells grow and grow and grow, and only it's one cell, so it's a clone, like Dolly the sheep. This is a clone of cells that expands. And in the words of my old mentor from my undergrad days at Cornell, Carl Sagan, There are billions and billions of these cells in the bone marrow. And their job is to fight infection normally. But what happens in myeloma is you're making all of this one type of cell, making all of this antibody, but you don't make any other antibody. And we think we've actually cracked the puzzle of why that's the case. You can ask me about that later, but you just make one type of antibody. So it says they crowd out other cells in the bone marrow. That's not really truly what happens. What we now know is they produce substances that suppress your ability to produce normal cells. And that's the reason a lot of people have low blood counts. They'll get anemia, or their white count will drop, or their platelet count will drop. It's not because it's physically crowding out. It's because it stops the production of other cells. And we think we know the culprits. That is the particular proteins that are causing that now. A lot of them not necessarily made by the myeloma cell, but other cells in the neighborhood. Now, since this is in the bone marrow, and if you remember the chicken bones around the inside's that kind of red part, that's the bone marrow, but outside of it's the white part. Well, there's crosstalk, and what happens is the myeloma makes the bones fall apart because it takes the cell, it tells the cells in the neighborhood to gobble up bone. It's kind of like the Pac-Man, it gobbles up bone. And that's a commonplace event in myeloma. So myeloma patients, what happens? They get bone pain, and they also get a lot of fractures. And we certainly see that, although these days that's pretty uncommon with the widespread use of bisphosphonates. So it's the second most common blood-based cancer. Number one is lymphoma. However, in the black population, it's actually more common than lymphoma. It says in 2009 there were about 71,000 people with it. I don't believe that. I think it's well over 100,000 now, and the numbers keep growing. And you'll say, well, why is that? Well, it's not only because we're diagnosing it more, because this is a disease of the elderly. It's because everybody's living a lot longer, so there's more of you guys walking around, thankfully. So the average age is late 60s, although I've seen patients when I was a medical student, the guy was 18 and as old as 99. It is much more frequent in the black population. The reasons for that are pretty unclear. That's true throughout the world. It's also true that it's precursor disorder, which my father-in-law actually had, so-called Iemmsg, is also much more common in the black population. It's a slightly more common disease in men than women. You see 54 to 46, not a lot different. And the symptoms vary a lot. In fact, many patients come in the door for a routine physical or an insurance physical. They're found to have a high total protein, and they're ultimately found to have myeloma. If you have symptoms, the most common one is the number 2 one there. It's bone pain, usually back pain. But how many 70-year-olds have back pain? 2/3, 70%. So, you know, a lot of times that's really serendipity, and it isn't really back pain that's resulting from the myeloma and the involvement in the fractures that can occur there. Now, you can't see anemia. That means a low red count because, again, you're suppressing your ability to make those red cells. You can bruise easily, particularly if your platelet count is low, and you may have infections. And they may occur from a low white count. And also, as I told you, you don't make antibodies. So if you don't make antibodies, you can get infections. The calcium level is high, and that's because as you're breaking down bone, what is bone? A lot of it's calcium. You release it, your calcium level goes up. And that can lead to the last sub-bullet down there, kidney damage. But kidney damage also may occur from a lot of other reasons. The most common is those proteins, especially parts of them called the light chain of the antibody. They get in the kidney and they clog it all up and cause kidney failure. But like I saw a guy yesterday, and I think the guys at UCLA missed it, I think he may have 2 things that are causing his kidney failure. One of them is gout. Yes, a lot of people with myeloma get gout because they have a lot of cells that are turning over rapidly, and they release something called uric acid, and that's what causes gout. And he also had something even rarer called amyloid, and that is something that can really foul up your kidney function. A lot of causes for reasons for kidney failure in myeloma patients. So the laboratory tests, we do blood tests. We measure routine things like CBCs. We also measure the protein. We not only do that in the blood, but we'll do that in the urine as well. Now, in terms of imaging tests, there are a lot of very expensive tests that my friends like to do, like CT scans and MRIs, and they add a lot to the healthcare dollar. I don't think they help the patient very much in most cases. But if you have specific areas of pain that need to be dealt with, certainly further imaging beyond just plain x-rays is worth doing. So we generally perform x-rays. Now we often are asked how often to do those. Well, 10, 20 years ago, we did them every year. Like a yearly mammogram, you got an yearly skeletal survey. And it turns out that was a big waste of time and certainly a big waste of healthcare dollars, and you got more radiation than you needed. So we don't do that anymore unless you happen to have to go on a trial or you're having progressive myeloma and we want to see what's going on in your bones. So to determine how advanced the disease is, the staging, it says the amount of M protein is measured. That's not really true anymore. We don't use the amount of that abnormal protein to stage you anymore. That's the system from the mid-70s from Drs. Dury and Salmon, when Dr. Dury was Dr. Salmon's trainee down in the University of Arizona. But that system's really been replaced by a newer one where we measure 2 other proteins in the blood I'll come back to toward the bottom of the slide. We also look at your bones, but again, that's part of the older staging system. It helps us, though, determine how much treatment you may need. The high calcium has also been used in this older staging system, but it's pretty easy to normalize that now. That's not really a good marker for prognosis. And the same is true of hemoglobin, which is a measure of how anemic you are. But we do use the next 2. We use the blood levels of a protein called beta-2 microglobulin and another one called serum albumin. So what is beta-2 microglobulin? Well, it's a protein that's on the surface of the myeloma cell. So if you have more cells, you have higher levels, that's not so good. However, we also know now that that protein is cleared in your kidney. So if you have diabetes or hypertension and your kidney function is off, that level's going to be high. It's not going to be a very good marker. Serum albumin is a healthy protein. So the more of that, the better off you are. And we use those to come up with what we call the ISS, or the International Staging System. However, you can kind of thankfully throw that away these days pretty much, because thanks to all the new therapies, regardless of your stage, you're going to do pretty well. The blood counts of the red or white cells, that's really the amount of hemoglobin has been used as well. I will mention in passing, we've just uncovered a new marker, which we think will hopefully eventually replace all of these. It's called BCMA, and it's a new serum marker to follow myeloma. It shed off the myeloma cells. It doesn't seem to be affected by kidney function, and it goes down and up with a response to treatment. So the goals of therapy. Well, the ultimate goal of anybody with cancer is to get rid of it. We can't do that very well in 2013. It says we try to slow the growth of the myeloma cells. I don't think that's the right term. I think what we're trying to do is reduce the tumor growth. The number of cells in your body are reduced, so they're having less impact on your bones, your blood counts, and your kidneys. So as a result of that, we hope to get rid of the bone pain, the fatigue, which may be from the anemia, the kidney failure, and any other symptoms you may have. And there are other symptoms that a lot of your doctors don't attribute to myeloma, but I do. Kind of, I feel crummy, so-called malaise. So we want you to be in remission for a long period of time, and of course, not only remission, but what I think is equally important, even more important in my view, is that you not only have, if you will, a complete response, but you have a complete life. So I think that's what it's about today. So I'd like to say we not only have to look at the impact of the disease, but our treatments. And we often forget about that. And I was talking to my sister on the way over here. She was unfortunately developed acute leukemia about 5 years ago. Thankfully, she's cured. But boy, she experienced side effects from the treatment. And I think our doctors often forget about that. So most treatment plans today for myeloma involve a combination of treatments. The myeloma-specific therapies may be single treatments, single drugs, rarely used today, more often combinations of different types of drugs. High-dose therapy has been used. I did a lot of that in the 90s. I made my brother a rather wealthy guy with a discovery he made of a way to get cancer cells out of the autograft you give back to the patient. But we've given up on those today. We think there are a lot of better options to treat myeloma than transplant. But I'll talk about autologous, allogeneic, and what we call reduced intensity allogeneic. Radiation therapy, really not used very much anymore, I hope. Unfortunately, too much in the community. I like to say radiating myeloma is like putting a Band-Aid on Hoover Dam when it's cracking. You got to deal with the whole structure. So we don't radiate myeloma very often. I radiated recently a gentleman, and that's probably the patient I've done in the last 5 years. That's the only one I've done. Clinical trials, well, we're big on those. And I was saying earlier to Dave and a couple other people, back in the 90s, clinical trials like Doug Flutie's Boston College Hail Mary pass. I mean, you really didn't think it was going to work. But now the clinical trials actually involve drugs that, in my opinion, in many cases are better than not being on a trial. The reasons for that are not only the superiority of the combinations in these trials, but the fact you get followed very closely by the doctors and the healthcare providers when you're on a clinical trial. And you certainly should be very vocal about side effects. And you really need to let your doctors know what the heck's going on with you in terms of that. We often just look at numbers. We really need to look at the patient. As my good friend Jacob, who's an oncologist and a lymphoma survival for 30 years this year, says, who actually was a patient at Stanford when my brother was a fellow, though Stanford being the mecca of lymphoma back in the 80s, he said to me, it's not about treating the cancer or the myeloma. It's not about treating the patient, it's about treating the person, and we really try to practice that in our practice. So treatment with drugs is a key component of myeloma treatment, if the patient needs treatment. Treatment may begin with a combination of drugs, and patients, not in our practice, but most practices, are assessed for whether they're transplant candidates or not. Again, we do not do that. Now, what's not in these slides is how do you decide who needs treatment at all? Because there are a lot of patients, including some in the room, that I take care of that I don't do anything for except for they give them a bone strengthener or bisphosphonate monthly. So who needs treatment? Well, many years ago, the Mayo Clinic came up with a term they called symptomatic myeloma for so-called CRAB symptoms. It's a crummy term, or crappy term for CRAB, because CRAB is really not a series of symptoms, but labs. The C is hypercalcemia, the R is renal failure, the A is anemia, and the B is bone disease. In fact, my C is not hypercalcemia, it's constitutional symptoms. So what does that mean? If you feel lousy, and you don't have any other reason for it, it certainly could be the myeloma. That may be from bone pain, that could be from fatigue, it could be from fevers that are unexplained, all of that. Now, renal failure. So if your kidneys aren't working right, but I just told you the guy who came yesterday, his kidneys are probably not working right from things other than myeloma. He also had diabetes and heart failure. And he had high blood pressure. All of those can cause kidney. So we often believe kidney disease and myeloma, it's not myeloma. So be careful that we're treating the right disease. Anemia. Remember, Heather came up to me from San Diego several years ago, and she'd been treating for myeloma for a year with one of my favorite regimens that some of you in the room have been on. And boy, what did she have? She had iron deficiency anemia. Little iron, her hemoglobin normalized, she didn't need any myeloma treatment. And the B is for bone disease. So bone disease, well, guess what? A lot of holes in the bones are really not holes in the bones at all. Perfect case, my friend Marty. Marty was on a trial with Celebrex for myeloma for many years. His protein started dribbling up. Sent him downstairs to get a bone x-ray from the radiologist. They said he had a bunch of new holes. I said, bring me the films. I looked at the films, said there's nothing here, and to prove it, I'm going to send you over to the best bone guy in LA, Jerry Meek. Jerry did the bone survey, said, you're right, there's nothing here. So you got to be very careful when people tell you you have myeloma bone disease. Because they see myeloma on the radiology requisition, boom, they find a hole in your head. Even though it's not really there, it's a hole in the head of the radiologist reading it. Okay, so let's talk about transplant, and it's kind of ironic that, like your kids, I have a perfect match, my identical twin. So I would get a syngeneic transplant. And you laugh when I tell you that when I was a med student in Seattle, my twin brother and I trained 40 years ago under the guy who won the Nobel Prize for transplants. And I coaxed him into being the initial invited speaker for the IMF at its inaugural event over 20 years ago in LA. Don Thomas, who actually recently died. So we used to make rounds with Don, and in those days he introduced us as a pair of normal identical twins, because in those days one had leukemia and the other one was the donor, and they were only doing identical twins back in the early 70s. And then about 15, 20 years ago, he said to my twin brother, he was on the board of several of his companies up in Seattle, he said, you guys weren't so normal after all, were you? So autologous transplant means we're going to give you back your own cells. And it seems kind of folly to give back cells, and these days we do it largely from the blood that are riddled with tumor. So my brother invented a device to pull out the healthy cells, and we actually proved in our lab that it was successful to do that. The problem is, as I like to say in the words of my own mentor again, Carl Sagan, the millions of cells we removed out of the autograft were far outstripped by the billions that remained in the patient. So even though that device was effective to remove cells, the high-dose treatment isn't very specific. And that's a major problem I have with transplant. I like to quote one of our board members. My wife's an actress, and this board member used to do a lot of theater with her in LA. And when he directed her, he'd say to her when she was on stage, it's not about more, it's about being more specific. And I think the problem with transplant and high-dose therapy, it's not very specific. And now, thanks to drugs like Velcade, Revlimid, we have a lot more specific drugs. And I think that's where we need to go with therapy over the next, hopefully, several decades. So we have very good responses now, even without transplant. It's not appropriate for all patients. I don't actually do it in any patients. I think that if you push me, I would tell you there's probably a 3% chance it's going to work great. Marlene, one of my favorite patients, a gifted artist, who's I'm going to see this afternoon at the Art Festival in Beverly Hills. She always exhibits there, and she's done our donor wall with the help of my wife. Wonderful lady. She's 16 years out. She got my brother's transplant procedure at UCLA in '97. But the dirty little secret of transplant, there's about 3% of patients, you make it worse. The disease gets a lot worse. And then about 94, we don't do much. So I don't transplant anymore. Allogeneic, the problem with allogeneic is we don't know how to do it without making the patient sick. Because what we're doing here is we're taking a donor, it could be a sibling, or it could be an unrelated person who's what we call an HLA or histocompatibility match. But it's not a perfect match. So when those cells go into you, they reject you. And that can wreak havoc. 20% of these patients die, and another 20% wish they were because they have such what's called graft versus host disease. Now, it is true there is a really small chance you can cure patients possibly with this, but I wouldn't go to Vegas on the 1 or 2% shot I'm going to get cured. The 20% I'm going to die, and 20% I'm not going to feel very good. And then there's this lower dose intensity transplant that people have tried, so-called mini transplants, mini allos. And there's been some work on that, but again, a lot of GVH, or graft versus host disease. So I talked a little bit about radiation therapy, and this is a modality that is way overused today to treat myeloma. Yes, myeloma is very radiosensitive, but guess what else is in the exact area that you're radiating? Your bone marrow. And you need to hold on to your bone marrow, and this applies to transplant too. You need to hang on to your bone marrow function in the long run to get all the treatment options available. So if we permanently damage with things like radiation therapy or transplant, we've done a short-term service, but a real long-term disservice to you. So many patients get radiated to relieve pain, in my view, unnecessarily. There are a few circumstances we may need to radiate, patients who may have a fracture and then need surgery. We're not so sure we even need to radiate those folks anymore. But there are people who have just one myeloma, so-called solitary plasmacytoma, one lesion, and you can radiate it and make the myeloma go away, and it won't happen elsewhere. Not a very often achieved outcome, unfortunately. But there are a lot of new things happening in myeloma. We have a lot of different new staging and response criteria. Frankly, we don't know how to use them to individualize treatment yet. We have a lot of new drugs, new combinations. You're going to ask me all about them. They're not very specific in here. And these have most importantly not only helped in prolonging your lives, but we figured how to use these drugs, I think, better. So not only you're living longer, but with much better quality. My favorite picture is my patient Jeffrey at the top of Mount Kilimanjaro with his wife while he was on a clinical trial. And his wife's an orthopedic surgeon, kind of coincidentally. He's got a big sign up there, "Thank you, Dr. Berenson, for getting me up here." And he's literally starting a new clinical trial this week. And he's been with me for a long time. And there's information available at visitmymultiplemyeloma.com. You can learn about myeloma, how to fight it, how to live with it, and share your experiences with others. And that brings me to tell you, my wife's putting together a series of patient vignettes, and we're writing a book about their experiences as to be a very hopeful sign for our patients about how well you can do, and not only in terms of length, but how well your quality of life can be these days, not only for years, but for decades with myeloma. And I think I'll stop there and take a bunch of questions. Okay, thank you. Yes.
Can you characterize what percentage of your patients become refractory to Velcade and what your advice, next regime would be for those patients?
Yes, I can. Well, it's a relative question. I would say the average length of response with Velcade in the frontline setting is 2 to 3 years average, but it could be patients who've had one treatment and are in remission 10 years out, and those that go into relapse mode in a few months. So it varies a lot. In terms of the percentage that will ultimately relapse, since we largely believe this is incurable, you'd have to see well over 90% at some point will become refractory. The beauty of Velcade, and the same is true with the newer version, carfilzomib, is that it provides a platform to make other drugs work better. So about 10 years ago, we published data out of our laboratory to show that this drug was not only able to kill myeloma, but more impressively, it could be, if you will, like the waiter who brings food to your table, it could be the drug that can make other drugs work. In other words, Velcade could work with steroids, with Revlimid, with thalidomide, with Cytoxan, with melphalan, with bendamustine, with Doxil, running out of breath, but with all of these different drugs. So the concept in oncology, and still is by many, believed by many oncologists, if that drug doesn't work, say Velcade, throw it out. Clearly not the case with Velcade. If you fail Velcade with one combination, you can respond to 10. For example, we're doing a clinical trial now in a patient who is doing quite well on it. He's had Velcade 13 different ways. Just that drug, a 13 combination. And he's having his best response now. So I don't think that, I think this is a little bit, I make it akin to that favorite I Love Lucy episode with her and Vivian eating chocolates off the conveyor belt. And Velcade is like the conveyor belt. You can try different chocolates. And we do not give up the ship. And we give treatment that I believe is well tolerated enough that they can keep on going. This gentleman has had 23 different myeloma therapies. And his quality of life is actually much better today than it's been ever before. Yes?
When relapse begins to occur, what would be the indicators to start taking action?
That's really a great question. Because people say if your protein's rising, it's time, if your markers are going up, you've got to do something. There's no compelling evidence that in the absence of the CRAB criteria, high calcium, worsening kidneys, lowering blood counts, or some new bone symptoms or disease, that you need to do anything. Most of us now, and we're writing this into the new criteria, that the rate of rise seems to be important. So if the protein is going up fairly rapidly, then we really think it's time to get in there and do something. I mean, I think the writing's on the wall if you're relapsing, but I've had patients, Susan, who's just now unfortunately relapsing off Revlimid and a steroid Medrol, and she's going off to Europe for a month. I said, go have fun, because her protein's going up pretty slowly. And in fact, she waited 17 months. She had been on a Velcade regimen, had done well, eventually failed, but she waited 17 months before she started the Revlimid. So it varies a lot. In some cases, it can be immediate, that you need to start. In other cases, it may be upwards of a year. There's no evidence of early intervention in the absence of this rapid rise or the CRAB criteria, the high calcium, kidney failure, anemia, bone disease, that you do any better. I would say these days there's so many options, I tend to jump in a little sooner than I did 5 years ago, because I know I have a lot of things I can do. Yes?
Some patients seem to have what they call high-risk cytogenetics. I read it's about 20%. Do you treat those people differently, and if so, how?
Oh, that's a great question. I love that question. So the question is, what do you do when the patient walks in the door new? Do I do cytogenetics? I don't. And you'll say, well, why don't you do that? Because although now it's 10% of myeloma is bad acting, those who have a missing part of chromosome 17, and perhaps those who have 414 or 1416, there is not a single oncologist in the world who can tell you what to give those patients so they will do well. They go to City of Hope and they go, you need a transplant. And I say to my patients, why don't you ask them what the outcome is in that subgroup? It's awful with a transplant. And I can't tell you I do much better, and I've been flogging a couple recently who had cytogenetics before they came to me, and they were awful, and they're doing awful, even though they failed transplant and everything else. It's a reducing number, though. It's a shrinking number now that are high risk, much lower than it used to be. For example, Velcade is able to overcome high risk, except for really the 17 missing chromosome group, which is a very small number now. We don't know how to deal with them. We flog them with more drugs, and we go, yippee, we get responses. They last a little bit longer than my talk today, but not much. Yes.
When you do have patients that are refractory to Velcade, is it the same clone that's becoming resistant, or is it the rise of a different clone?
That's a really good question, and there's a lot of controversy about this. And it brings me to tell you that recent data from Mayo suggests that, in fact, sensitive clones come back, which is pretty interesting. So say you got Velcade 10 years ago, and then you started getting some other drugs in the interim. That clone can come back again that was Velcade sensitive, and you can be sensitive to Velcade again. Who would have ever thought that would be the case? But there's a lot of controversy over whether the clone is evolving or whether there's subclones growing out. The data now suggests the subclones were there, and there's just outgrowth of small numbers of subclones that were already present that are resistant. In other words, the sensitive clone went away, but this resistant clone now takes over. And it was there all the time. Yeah. Yeah.
What's the prognosis for stage 3?
Well, as I told you, to me, in 2013, staging is pretty irrelevant because we have such great drugs today, and the VISTA trial, which was a Velcade, Melphalan, prednisone trial done outside the U.S., in the group that got to Velcade, stage didn't make any difference at all. It was stage blind because now we have all these great new drugs. I don't really care what the stage is anymore. I think it's probably lead time bias. It's like breast cancer data they've been generating, saying people are living so much longer with breast cancer. Well, a lot of it is because we're diagnosing it early. And the same is true with myeloma. So you may be diagnosed later, okay, with the disease, and you may not live as long because